All right, patient 2, knee pain. A 25-year-old male with a history of patellar tendonitis of the right knee and surgically repaired lumbar disc herniation presented to the orthopedic sports medicine office for consultation regarding left knee pain for approximately 2 weeks. Okay, so this could be either acute and it's just lingering and or a developing chronic condition. History. The patient had presented to the emergency department 2 weeks prior for an injury occurring during volleyball, where he had jumped and landed predominantly on his left leg, causing it to buckle. So it's not a chronic injury, definitely acute. And typically with this mechanism, we're looking at ACL, possible meniscus, um, maybe even MCL if you get the unhappy triad. He had immediate discomfort in the joint, which persisted as a dull, throbbing pain. Okay. There was no painful popping or clicking, so not a meniscal tear. Could still be a contusion with it, or it could actually end up being a bone bruise. Additionally, the patient's knee did not catch or lock and had not been giving out. So the ACL may not be completely torn, but it could be more of a grade 1 or 2 sprain. He had noted pain with ambulation, using stairs, sitting for prolonged periods of time, and raising up from sitting. Okay, so it sounds like when he does not move it, from when the time was that he was not moving it to again initiating movement causes most of his pain. The patient had been using a straight leg immobilizer and crutches to assist with ambulation and taking ibuprofen as needed for his pain. Okay. Physical examination. Inspection. Soft tissues were noted to have mild swelling. The patient's gait was antalgic. So the patient has a limp. Soft tissues, has mild swelling. Don't really know if this is within the joint or like effusion type stuff, or if this is more edema based. Palpation, the joint line was tender on the lateral aspect. Okay. There was facet pain to palpation of the patella. Patient's neurovascular exam was within normal limits, so no numbness, tingling, anything like that, including the motor, sensory, and pulse examination. Okay. Patellar reflex was 2+, so that's a normal reflex. Range of motion, knee flexion to 90 degrees and extension to 5 degrees. So it does not have full range of motion. Typically knee flexion goes to about 120, and the extension could be to 0 or potentially -1 or -2 if the knee goes into hyperextension, if that's normal for that person. So after going over all of that, I'm thinking could be a sprained ACL and or a meniscal contusion coming down from that jump, and the femur coming down with all the pressure going straight onto that meniscus. Could have really irritated that, or bone bruise as well. But bone bruise and meniscus are going to be treated the same way. It's just more or less, does he have an increased laxity with a Lockman's or anterior drawer that we don't have any information on this to go off of. So I'm between those.